will skip to the next speaker. We have, sorry? Okay. We have the pleasure to introduce, since he's already available, Dr. Leung from Toronto, Canada. He's also head of the 7th Surgical, and he will show us a very interesting application, so particularly interesting for neurosurgeon and for surgeons in general, about machine vision-based intraoperative anatomical recognition. So Dr. Leung, are you with us?
Hi, yes, this is Mike here. Thank you for the introduction. Let me try to share my screen and okay, there you are. I hope everyone can see me on my video, and I will start my slides.
Please,
give me one moment. Share screen. All right, there we go. Can everyone hear me and see my slides and see me in person?
Yes, we see very clearly.
Okay, great, thank you. So thank you again for the introduction. So this will be a short talk. I'll spend a few slides to talk about what it is that we do here at the 70 Surgical in Toronto, Canada. And I will follow by how we can leverage machine learning for image-guided surgery of the spine. So my role is as VP of Software Engineering at 70 Surgical and one of the co-founders with the company since the beginning. All right. I'm guess so these first few slides should be familiar with neurosurgeons, but just for a general audience, I will just go through a few slides. So here is an example of a scoliosis case that we performed recently, and you can let me get my laser pointer up. You can check us out on LinkedIn. These are all public images. So here, this is a kid that had scoliosis. We put in 25 screws, as you can see here in these slow shots before and after. 25 screws were navigated, no radiation was required. So a big thing for us is no radiation to be able to put in these pedicle screws in the spine. So just background information, if you're a neurosurgeon, you are familiar with this vertebral column. And what we're trying to do is, for example, in the previous slide, we're trying to correct for the deformity. And to do so, what we do is implant pedicle screws. So these are screws that are inserted into the pedicle of the region. So these are cross-sectional cut of the vertebral column for vertebra, and then the spinal cord is right there. These screws are actually much thinner than what they're actually used when they're actually used in the OR. They're usually much thicker. So there's the margin for error for putting in these implants is not high. Generally, we require these systems to be able to guide the surgeon with millimeter accuracy. So 2 millimeters is generally what we need. And so you see that there are screws put in the spine, and then the rods connect the screws, and with multiple screws, multiple rods, or you can straighten out the spine. And that's the context. So at 70 Surgical, this is the system that we have developed, designed, and do everything from scratch: software, hardware. So what are we good at 70 Surgical? I think the easiest way or most brief way of saying it is we are the fastest way to view axial cross-sectional images for surgical guidance without the need for radiation. And I'll kind of expand on what this actually means. Cross-sectional images without radiation. So with image-guided surgery, this system is used to guide the surgeon into telling them where an instrument is. For example, this is the pedicle probe. These are cross-sectional images of the spine. So with X-rays, you have these different planes. We're pretty familiar. Coronal planes, you can get it from X-ray, fluoro, tube and detector on either side, the back and front of the patient. Similarly with the lateral shots here, you're seeing the yellow plane here. You can put the tube and detector, but you can't really do it by putting a tube and detector on the head and the feet. So these axial type of images, because cross-sectional cuts in green here, are available not through fluoro shots. And this is what surgical navigation instruments allows us to display to the surgeon. So as you're putting in these implants, so here the surgeon is first creating a pilot hole, making sure they don't go into the spinal cord, make sure the pilot hole does not go into the outside of the vertebral bodies where there are nerves and blood vessels. and to kind of give them just a peace of mind that where they're going to put the screw is where it's actually going to end up. So here are just some examples also from LinkedIn public information where this is a cadaver lab. The system is used in there are 50 plus systems, commercial systems out there in US, Canada, New Zealand, Australia, some Southeast Asian countries, and we actually recently got into Switzerland as well. So these are actually screenshots from a road trip at Switzerland. So you see that this is the specimen, cadaveric specimen for these lab. This is what the surgeon sees in real time. And yeah, beyond what we actually do with the hardware and system, we also manufacture surgical instruments. And yeah, so I'll just keep going. It's just in case I don't see any chat windows, please feel free to interrupt me or ask questions. Otherwise, I will keep going. Okay, so here I'm going to show the clinical workflow. I think the main purpose here for me is to just show you what we do at 7D. And if you want more information, you can contact me or visit our website. So this is the surgical workflow. When the foot pedal is pressed, there's a flash of light that are used to digitize the patient. So here you actually see a 3D image of the patient as the system sees in the operating room. We've loaded a preoperative CT, and in about 30 seconds or so, we're navigating. So you can see that the blue is a tool that the surgeon is holding. It's tracked in real time, and it's showing you where the tool is relative to the bone or the spine. And that's pretty much it. They're longer videos with more details, but I just want to give you a sense of the speed at which you can do these registrations and get to navigation. And really our biggest advantage is that we can register to each individual spine level independently very quickly. So in these huge deformity cases where you have to operate on 20, well, maybe not 20, but 10 spinal levels, it's very efficient compared to the existing solutions. All right, so that's kind of my spiel about 7D Surgical and what we do. The next part is I want to talk about image-guided surgery using our 7D Surgical system. And since this is a machine learning conference, what are we using it? What can we use it? What can we use machine learning for as related to our 7D Surgical system? So the overview is I'm going to go through the data sources that are utilized by the 7D Surgical system for a spinal procedure. We also support cranial procedures actually, but I'm going to focus on spine today. And how can machine learning be applied to these data sources to improve or augment image guidance? All right, so go through each kind of data. So the first is the preoperative image data. So these are the 3D volume of the spine, usually acquired preoperatively using CT. And the first problem that we can apply machine learning for is vertebral segmentation. What do I mean by that? So next, I'm going to show a few screenshots on what the software application actually looks like. So here I've loaded a CT of a data set. The software automatically generates a surface of the CT, and here I've planned the surgery for L2, L3, and L4. Okay, these are the lumbar region, and I'm just going to flip through them. You can see that I planned out these different regions, and segmentation has been performed to highlight these regions. And why is segmentation necessary for registration of the spine for image-guided surgery? The reason it's needed is because, first of all, the spine is mobile. So as you work on the spine, these different segments of the spine moves relative to each other. So you need to make sure you're only registering at one site at a time when you're operating on those levels. So there's a preoperative CT that you're always trying to match to the intraoperative spine, and the preoperative CT is not going to be in exactly the same orientation or position relative to each other, pre-op and intra-op. So we need to register to each level independently, and segmentation is required in that regard. And the bottom message is, I guess I'll say, the better the segmentation is, the more accurate it is the registration process. and subsequently the navigation accuracy as you're using it for spinal surgery. Okay, so that's the first problem. I just want to bring up that there is a large data set that is available to train machine learning algorithms for vertebral segmentation. This VERSE challenge, I was there actually last year in 2019. This have this data set with labeled data that you can train your algorithms on to segment out different regions of the spine. And I've only mentioned why this is useful for 7D surgical, but there are a variety of applications that where segmentation of the spine is actually of each vertebrae is very important. What we can also use this here at 7D surgical as well is detecting this intraoperative selection of spinal level. So what do I mean by that? When we're doing registration, we actually have to tell the system which level of the spine we're working at. I'll just go back to the slide. The system is currently not smart enough to differentiate L3. Well, actually, this is L2 versus L4 because they're also similar. Our eyes might be able to tell the difference, but even surgeons are sometimes not able to tell the difference intraoperatively. When you see the whole CT scan, you kind of count levels. You have ribs to go by, but in the OR, where all you see is a cut and some exposure of the bone, sometimes you miss what level you're actually at. So I'll say that it more often happens than not, or it's much more often than it's reported that the surgeons would actually operate on the wrong level of the spine. Usually it's caught before the surgery is over, and they would do a fluoro shot to ensure that the screws are in the right place. And sometimes they find out that, hey, I wanted to put a screw in L3, but it's actually in L4, so they have to pull it out, and that increases surgery time. So the question here is, can we actually detect if the surgeon has selected or is working on the wrong level? And using some intraoperative data sources, which I'll talk about next, we are working, and we actually can at least indicate to the surgeon that, hey, doc, maybe you're one level below or above where you're supposed to be. So there's some classifier that can be trained. And so here's some example where the pre-op data can be, and machine learning can help us with these problems. So it's not enough to just get the intraoperative data. We also need intraoperative data sources. And this is where 7D technology also shines. This is what I'll talk about next. So the next item is intraoperative surface data. So in the OR, what we can actually acquire with our imaging system is the three-dimensional point clouds of the surface of the patient. So this is just kind of schematically, this is what it looks like. This is a cut onto the back of the patient. And we've digitized using our system, the three-dimensional geometry, along with all the details, colors, and all that. And we use this information to register the patient to the preoperative scan. Okay, so this is what the system looks like. The 7D surgical system looks like. There are stereo vision cameras on the system, and there's also a projection system. And with these components, I'll just go through very briefly how we get a 3D surface out of it. Essentially, it's really just simple math and triangulation. You have two cameras. The cameras have known fixed distance relative to each other that you know beforehand. You know about the lenses. So from a so the camera system is calibrated, and you have the patient that the cameras are seeing a slightly different perspective. And essentially what the system sees is that there's a left camera, there's a right camera, and they see the patient slightly differently. And if you want to say, hey, where is the shoulder location of the patient in 3D, so in real world 3D space, in XYZ coordinates, you can see, okay, the left camera image, the pixel is here, but it's actually slightly shifted on the right camera because of they're looking at slightly different things. And by looking at the shift in distance between the site of interest, you can actually calculate how far that object is relative to the cameras. And you do it for every single point in the image, you get a 3D point cloud coming out of it. And the different ways of doing imaging, currently we use something called structured light, so that the projector system allows us to encode the surgical field. But if you don't have a structured light, here's where another problem that machine learning can help us. Stereo matching using machine learning. So this problem of creating a 3D surface is completely well defined if you know correspondence. So if you know this point correspond to this point, then it's just a simple math. But the difficulty is you don't know. Our eyes can probably tell, hey, the head is over here in this image, but the head over there is slightly shifted in this image. But it's not easy for a computer system to tell the difference. So machine learning here can actually help us to say, hey, this is actually the arm, and this is the same arm on the other camera, and now we can do just this calculation with a calibrated camera system to figure out this, create this point cloud. So that is intraoperative surface data. I think I'm just going to go. I think I have a bit of extra time, so I'm just going to go through. I just have one last slide. This point cloud that we're actually. So for each point on the image, we do this triangulation calculation, and let me just get to play again. Okay, so these are millions of little tiny points that looks like a surface, but each point has been kind of matched stereo correspondingly matched between the left and right cameras in order for us to create this 3D surface. All right. And I'm actually at my last slide here. The third source of information that we have is video data. So we have this computer vision system, and we are able to get a live video of the surgical field. So we can get a 3D image, but we can also get a video of what's happening in the OR. So next, I'm going to show just a picture of one of these pictures we took with our camera system in the OR. I blurred out some of the more gruesome stuff, but I think this audience, we should be fine. So this is what it kind of looks like. This is the incision that I blurred out, and it's essentially just this. And you would take 3D images of this incision, you would register it to the pre-op CT, and then you get navigation information, axial cross-sectional images, navigation as you're moving your tool around and you're putting in these implants. And how does machine learning help us in this area? Well, there are opportunities for us to do object localization and labeling with these images. So here I actually have different. This is just mocked up, but potential applications are identifying the tools that are within the surgical field. So this could be used. This video could be automatically annotated for training purposes. We could automatically identify where the reference frames are. So reference frames, I didn't really go into in detail, but it tracks the patient's breathing motion so that everything is in sync and calibrated. We could also track, identify implants and maybe do real-time measurements. So there are different things that we are exploring to do with the live video feed, which is available. It's just looking right down into the incision. Yeah, here's another opportunity where machine learning can make a difference. All right, so I think that's it. This is my contact information, and I'm open to questions. Thank you.
Thanks a lot, Dr. Leung. Truly fascinating work what you're doing there. So we have a question from the audience. So from Marco Archila, commenting a very interesting presentation. Could you comment on the precision of the system, of your system? Yep. How is it achieved?
Yeah, I can answer that. So according to the regulatory bodies, FDA, we have to be less than 2 millimeters because of the tight pedicle space that where the screws go in, especially in the thoracic region. So definitely less. It has to be less than 2 millimeters, but we can do better.
How can you achieve it?
By having better algorithms, better registration, better imaging, better sources of imaging, smarter algorithm to the difficulty with registration in the operative environment is it's just not ideal. There's blood, there's tissues, lights, different lighting conditions. If the world was ideal and imaging is perfect, the CT scan is perfect, then the resolution of the accuracy is really limited by our 3D structural light imaging system. So the more accurate we can map out the patient's anatomy, like the bone surface during the in the intraoperative sense, the better we can register that to the CT scan. But there are different things that gets in the way. So the smarter our algorithms, the better we can achieve better accuracy.
Okay, thanks a lot. Thanks a lot again for your work.